Namaste. My name is Shaikh. I am presenting the subtopic of malnutrition. I am a BCEd student in Shripal hospital under guidance of Dr. Anil Prakash. So malnutrition, it is defined as a set of pathological conditions which arise coincidentally due to the lack of proteins and calories. It can be divided into overnutrition as well as undernutrition. We will be presenting undernutrition. So undernutrition, the indicators for undernutrition can be stunting, which is height for age, wasting, which is weight for height, underweight, which is weight for age, and mid-arm circumference, and also due to the absence or presence of edema. It can be acute or chronic. Acute, it arises in a short period of time, that is, for example, 1 month. Chronic, it arises over a long period of time, that is for 6 months. The indicators of acute malnutrition, they are weight and mid-arm circumference, whereas for chronic malnutrition, it is height and head circumference. So these are the indicators. There are age-independent indicators also, which are mid-arm circumference, which can be classified by Arnold's classification, in which more than 16 centimeter of mid-arm circumference is normal, 16 to 13.5 is moderate malnutrition, less than 13.5 is malnutrition. And also in India we use Shakir's tape, which has color coding of green, yellow and red. Green is for 13.5 to 12.5 centimeter, yellow is for less than 20.5 centimeter to 11.5 centimeter, and less than 11.5 centimeter indicates red. And there is a bangle test. In bangle test, the internal diameter of the bangle is 4 centimeters. So if you are able to pass the bangle over the elbow of the child, then he is in severe acute malnutrition. Then there is skin fold thickness. Skin fold thickness is typically measured over the triceps and subscapular fat, subcutaneous fat. Normally it is more than 10 millimeter, and if it is less than 6 millimeter, then it is malnutrition. Then there are ratios of mid-arm circumference to head circumference. Other is chest circumference to head circumference. Chest circumference to head circumference. These both ratios, they equal at the age of 1 year. But if a child is beyond 2 years, and if the head circumference in such a child is more than the chest circumference, then he is under malnutrition. Then there are various classifications. For example, there is WHO classification, which classifies into moderate and severe variety. It is based on the standard deviations. Moderate variety is between -2 to -3 standard deviations, and severe variety is less than -3 standard deviations. Then there is IAP classification, which is based on weight for age. There is Gomez classification, again on weight for age. Wellcome classification, again on weight for age, but also it encompasses edema, the presence or absence of edema. Then there is Waterloo and Jelliffe classification, again for weight for age. Then it can be broadly classified as mild, moderate or severe acute malnutrition. Mild malnutrition, it represents as underweight or chronic anemia or in the presence or absence of infections. Whereas moderate variety, it can be clinically divided into 3 terms, that is marasmus kwashiorkor and marasmic kwashiorkor, and the third one we have is severe acute malnutrition. So the general pathological changes in malnutrition, if we go from the mouth, there is atrophy of the mucosa in the mouth, it becomes more shiny, the papilla of the tongues disappear, it becomes more smooth, and in the intestine there is atrophy of the villi there, and then we go to the pancreas. In pancreas we have more manifestation on the exocrine functions than the endocrine functions. Then in the liver we have fatty deposition, we get fatty liver and triglyceride deposition. And then in the endocrine system there is increase in the growth hormone in presence of malnutrition. There is thyroid fibrosis and adrenal atrophy, and in case of CNS, over time there is cerebral atrophy and decrease in head circumference. In the moderate nutrition, it typically appears between 9 months to 2 years of age. There are 3 varieties of it, that is marasmus and kwashiorkor. Marasmus, the differences between marasmus and kwashiorkor. Marasmus, it can represent from birth up to 2 years of age, whereas marasmus, it appears from 1 year to 2 years of age. There is dilution of feed which leads to marasmus. There is failure to gain weight. The child typically represents as only skins and bones. The look of the child is of a wise old man. The child on a conscious basis, he is listless and is disinterested in the surroundings. There is typical absence of edema in marasmic child. There is gross loss of subcutaneous fat, and the head is typically large. In a marasmic child, the head is typically large than the body, and the child is alert, the child is conscious, but he is not interested into the surroundings, and there is moderate variety of anemia. Whereas in kwashiorkor, it represents from the age of 1 year to 3 years. There is typical presentation of edema. The edema, it starts from around the eyes, then it goes over to the ankles, then the dorsum of the foot, and then it appears in the whole body. The edema, it is typically pitting edema, and there are 4 varieties of edema. There are 4 grades of edema in a kwashiorkor child. The first one is pedal edema. The second one is pedal plus facial edema. The third one is pedal plus facial plus spinal and chest edema. And the fourth one is generalized edema plus ascites. The child is typically irritable. He has a moaning cry, and the edema also, there are 3 factors which lead to edema in a kwashiorkor child. That is, one is loss of tissue, the second one is low osmotic pressure in the vasculature, and the third one is low albumin, that is low protein in the child. And there are 2 specific features of hair and skin. The hair, initially it becomes dry, it becomes lustreless and thin. So as and when the management is done and the child undergoes recovery, the ends of the hair, they gain the normal color and normal luster. So there is a flag-like sign in the hair. And then the skin changes, which are termed as dermatosis. There are large areas of erythema initially, which overgoes to hyperkeratosis. And this hyperpigmented skin, it starts peeling off in large areas. So it is also known as flaky paint dermatosis. And at a point, there are alternate bands of hypopigmented and hyperpigmented skin, and that is also known as pavement dermatosis. The liver in your kwashiorkor child is typically enlarged, it is fatty. Marasmic kwashiorkor. Marasmic kwashiorkor, the child represents initially as a wasting, severe wasting, but later also has edema. So it is a mix of both marasmus and kwashiorkor. The basic difference in a marasmic and kwashiorkor child, marasmus is due to loss of calories, and kwashiorkor is typically due to loss of proteins. There are also lab parameters to differentiate both. There is albumin. The albumin is normal in a marasmic child, serum albumin, whereas it is decreased in a kwashiorkor child. The urine creat is decreased in kwashiorkor child, whereas it is normal in a marasmic child. There is severe anemia in kwashiorkor child, whereas it is normal in the marasmic child. The third variety is, we have severe acute malnutrition. Severe acute malnutrition, it has 4 criteria. That is severe wasting, one. That is second is weight for height is less than 3 standard deviations. There is presence of bipedal edema, and the mid-arm circumference has to be less than 11.5. So the severe acute malnutrition management, it is divided into 3 phases. First is stabilization phase, which occurs over the first 2 days of management. Then there is a restoration phase from 3 days to 6 days of management, and then there is a rehabilitation phase from 2 to 6 weeks of management. So there are particular diets which are fed to the child. In stabilization phase, there is F75. F75 diet, it is low energy, low protein diet. Then in the restoration phase, there is F100. F100 diet is thick, it is dense in energy and protein. And then in the rehabilitation phase, we have RUTF diet. There are 10 specific parameters in the management of severe acute malnutrition. Number 1 is hypoglycemia, number 2 is hypothermia. Then in that order, we have to correct these deficiencies: hypoglycemia, hypothermia, dehydration, electrolytes, infection, micronutrients. Then we have to start the initial feeding, catch-up growth, stimulation of the child, and then follow-up. So failure criteria in the management of severe acute malnutrition. If by the 4th day there is no gain in appetite, or by the 4th day there is no start in decreasing of edema, then it is failure. Or by the 10th day there is still presence of edema, it is failure. Or by the 10th day the weight gain is less than 5 grams per day, then it is